Good afternoon and happy Valentine's Day. Welcome to the second value-based purchasing webinar sponsored by the Healthcare Authority. My name is Marty Teese. I'm account manager for the Centers of Excellence program. I'll be sharing presentation duties today with John Hendricks, senior manager at Primeira Blue Cross, and Krista Christensen from Virginia Mason Medical Center. Today's webinar highlights HCA's Center of Excellence program and its use of bundled payments as a strategy to deliver quality care. This is a benefit available to eligible public employee benefits members. Calendar 2017 was the first year of this program, providing a bundled episode of care for total joint replacement. That's either a knee or a hip. And just so you're not wondering, we did do 95 of them this year. On the slide before you, you have two audio options. You can use your the microphone on your computer, or you can dial in on the telephone. If you have any questions, you can use the question section of the webinar window. All right, first a quick overview of what's on the docket. To level set first, I'll run through some, I'll run through some of the background information, how the Centers of Excellence, sometimes I'll refer to it as the COE, how the COE program came about, the quality standards and the design benefit. Next, John from Primeira will talk about their work as third-party administrator, how they work with PEB members to facilitate their journey towards surgery and recovery. And after John, Krista from Virginia Mason will discuss their clinical approach to total joint replacement in this program. And finally, I'll come back and provide a look at some of the results from the first year with this particular bundle, total joint replacement, and we'll have questions and answers after that. I think we'll have time. Again, you can ask your questions at any time with the panel on the webinar. So let's get started. First of all, why is the Centers of Excellence, the COE program, a value-based strategy? Listed here are several essential tenets of what value looks like in healthcare. Very simply, for us, value is about better care and better outcomes for those we serve. Having Centers of Excellence is a way to point our members toward what we believe and what the data show is the best care available. That's value. Identifying a Center of Excellence for an episode of care is to recognize a high concentration of expertise and resources associated with that particular episode of care. Generally, any COE will be a place using clinical standards that are best practices, a place that measures their outcomes, and they're among the best, if not exceptional, and a place that respects, educates, and consults with patients as an integral part of the clinical process. So what's a bundle? A bundle is a set of services, the usual set of services associated with a condition or a procedure. When a provider or facility is paid a designated amount for the complete bundle, unnecessary or duplicative procedures are discouraged. Bundles implemented nationally, especially over the last decade, have been shown to encourage collaboration and cooperation between providers. And when you reduce unnecessary care, bundles have also been shown to minimize, if not reduce, costs. Starting with quality, excellence begins with best practices. In 2011, the Washington State Legislature established the BRE Collaborative, a body of healthcare professionals and stakeholders whose charge is to establish best practice approaches to improve quality and reduce variation in outcomes and cost For those who want to take a look at that statute, it's in RCW 70.250.050. 70.250.050. One of the first healthcare services that the BRE took on was total joint replacement. Nationally, whenever states or health systems begin a bundled payment strategy, they usually kick it off with a total joint replacement bundle. Why is that? First, there are a lot of them, over 1 million a year in the United States. Second, costs for these procedures can fluctuate drastically, and outcomes vary from poor to good. As elsewhere, total joint replacements, or TJR, was a great place to begin for public employee benefits. There's high utilization, over 600 procedures per year on average, varying costs and outcomes, and the BRE had already established a set of best practice criteria for total joint replacement. So here's what our bundled TJR benefit looks like. First, eligibility. It's available to Uniform Medical Plan Classic and CDHP members, but they can't have Medicare as their primary coverage. To be clear, these members aren't required to use the Center of Excellence. They can go elsewhere, but we try to incentivize them to use the Center of Excellence. This particular bundle includes case management and consultation. It includes the surgery, the implant, and the inpatient stay. It also includes transportation and accommodations while at the Center of Excellence. A few who are referred to the COE may not receive a surgery if the BRE criteria determine surgery to be inappropriate for them. Most, however, do proceed to surgery. Aside from proven quality, another incentive for our members to use the COE is low to zero out-of-pocket costs. Everything is covered. For CDHP members, this is our high deductible plan with UMP. CDHP members must pay their deductible first. The bundle even pays for parking and lodging and even airfare if airfare is necessary from designated airports around Washington. These surgeries are also warranted. Specific post-operative complications are the financial responsibility of the Center of Excellence, not PEP. So, who is the Center of Excellence? The RFP for this contract was issued in late 2015, and the Healthcare Authority anticipated multiple Centers of Excellence. As it turned out, we selected only one, Virginia Mason Medical Center, for their experience with bundling, their early adoption of the BRE criteria, and evidence indicating consistent, high-quality outcomes after joint replacement surgeries. As third-party administrator, we chose Primeira, who provides an array of customer services for COE participants, from initial inquiries to the post-op surveys. A little more chronology. We publicized this new benefit quite heavily during open enrollment in 2016, and Primeira was present at all the benefits fairs that year. We also issued certain sidebar notices and various publications announcing this new benefit. We went live January 1st of last year. Year one was mostly about building our operations and our working relationships, and we'll speak more about this later. As I mentioned at the outset, 95 surgeries were completed at the Center of Excellence in its first year. So that's the background. Now I'll turn it over to John Hendricks at Primeira Blue Cross, who oversees the administration of the program. John.
Thanks, Marty. and thanks everybody for taking time out on your Valentine's Day and lunch hour to listen in. Go ahead to the next slide, please. The Centers of Excellence Bundle program provides Primeira an opportunity to help folks who are in a position that's really life-changing. Getting a knee or hip replaced can really help make the difference in somebody's life. And it also gives us the ability to demonstrate our values and really be in the corner of the patient and the care companion as they go about their care journey and afterwards return to their life. You know, maybe make that journey and all the things that go along with it a little less daunting. Our company has deep roots in Washington, and we're pleased to partner and support the Healthcare Authority in this endeavor. In addition to the Healthcare Authority, we have the pleasure of serving more than 2 million people worldwide with their healthcare journey. Next slide. So what makes up our Concierge Services for this COE program? In general, we're here to explain the benefits and requirements of the program to prospective participants and their designated care companion, help them gather what they need prior to their consult with Virginia Mason, and then ask them how everything went after they're discharged. We also do a lot of behind-the-scenes work, from program communications, as Marty referenced earlier, to administering the COE bundle program payments for eligible expenses like lodging, mileage, etc. And again, that post-discharge survey. Next slide. So let's take a look at an illustration of the customer journey and how we support the program participants at each phase. So this is just a snapshot of the entire customer journey. My colleague Wesley Madsen put this together. Great job, Wesley. Shout out to you. And we describe a 5-step process, but of course you could combine these. We just wanted to spread these out to get a better understanding of what we do. So let's take a closer look. Go ahead and go to the next slide. So the identification phase is just identifying folks who would benefit from the program. And of course, not everybody wakes up thinking they're going to get a knee or hip replacement. It involves making them aware of its benefits. And that involves broad as well as targeted communications, together with a microsite and embedded video featuring Virginia Mason's Orthopedic Center and walking them through the program, as well as just being there physically at open enrollment meetings to just have that chairside conversation. Of course, not all plan members decide to follow up with the COE, but as we'll get to in a moment, we enjoy a very high adoption rate based on the approach taken. So let's go to the next slide. Once we identify a UMP Classic or CDHP participant who's eligible for the COE bundle, we focus on educating them on the next steps in their care journey and their responsibilities in the process to really make them a student of what they're about to go through, as well as a cooperative patient that's invested in their outcome. And a big part of this involves a care companion selected by the joint recipient to be there during their treatment as well as their recovery. Also, during this step, we really try to build a rapport with the COE bundle program candidates and their care companion, make through a host of phone conversations to make them feel welcome to the program and comfortable with their next step, which of course is the pre-surgery consult with their Virginia Mason surgical team. And we furnish them a welcome packet at this phase so that they can not only hear what we have to say over the phone, but then in the comfort of their own home to review that at their leisure for additional information. Next slide. And I would also like to say, up until this point, a lot of the information that we capture is self-reported from the person. In addition, we of course help them gather a lot of information and take the burden of some of that paperwork gathering off their shoulders. So the next phase is when they're approved for surgery, when they have surgery, and then they begin the recovery. At the surgical consult, the surgeon and care team confirm all of the information we've gathered, and they determine final fit for the program based on the BRIE criteria. In rare instances, something may surface which poses potential complications to a successful outcome, and the surgical team may elect to defer that person's participation in the program until they can address those issues. Examples of this would be nicotine use, a BMI or body mass index over 40, etc. Otherwise, at this stage, a surgery date's finalized and the participants receive additional education through the Virginia Mason resources and access to make their journey and stay as positive as possible. We also provide them with a journey packet that includes a lot of additional information together with parking vouchers and some instructions on some of the creature comforts they can expect at the Inn and Baroness, which are the hotel adjacent to the hospital. And then when they're home, about 30 days post-discharge, we call them through a separate unit on our team via phone call to go over the entire care experience. And I would add that their entire interactions with us is really over the phone. It's person to person. None of it's done through SurveyMonkey or anything of that nature. It's a very high-touch model we're striving to achieve. Next slide, please. So what we strive for is a great outcome and a great patient experience together with the care companion. Here's an actual comment from a survey reported by a COE program participant. And this is reflective of the vast majority of survey participant comments. Even where we have constructive criticism by a patient or participant, they still rate the program very highly. And that's something we really appreciate with this population. Not only are they willing to give us great feedback, but they really appreciate the value that the Healthcare Authority team has put together through this program. And for every one of our team members, it's really exciting to be a part of something that makes such a positive difference in the lives of the people that are using these services. Let's go to the next slide to get a sense of some of the metrics behind the scenes. So as we conclude this portion of the presentation, this just gives you, really a first-year snapshot of some of the dynamics of the program from our perspective. The welcome packets are really there initially when someone signifies initial interest in the program to describe it. And so we just picked that as kind of an entry point in the process. If we would have used the journey packet, which is the packet that they receive once they're a fit for BRIE, you have that information too, and it would have been a different look on the graph. But what this basically says in these terms is for every person who gets a knee or hip replaced through this program, there's 2 welcome packets that come out. And that's just, generally gives you a pretty high adoption rate. And then when you look at the number of journey packets, it's actually an even higher adoption rate. So in our effort, we provide Virginia Mason with a patient that is educated going in, is very supportive of the shared decision-making process, and is really there as a partner in their outcomes together with their care companion. Next slide. Today, the program enjoys wide support for UMP Classic and CDHP plan participants, and we would also say positive word-of-mouth support. Again, we enjoy being part of this and look forward to the future. Krista?
Now, can you guys hear me okay?
Yes.
Okay. I wanted to make sure that I pushed the right button. So good morning. Thank you for tuning into this webinar. Oh, next slide. So Virginia Mason, we're located here in Seattle. We also have several regional medical centers throughout the region. as well as our sister hospital over in Yakima. Really here in the downtown Seattle area, we're a tertiary and quaternary referral hospital, and that we specialize in a lot of that specialized care. And we're almost 100 years old, and we have about 450 plus employed physicians. We also have some community practice providers that practice at Virginia Mason. We have some national relationships that I think are important to this conversation, with the High Value Healthcare Collaborative, the Pacific Business Group on Health, Walmart, Health Design Plus, and the Healthcare Authority, obviously, who we're partnering with on this presentation. Next slide. So Virginia Mason, we have actually, I think, a very succinct strategic plan. We use it in how we start all of our meetings. And it really guides us. It's our true north. It's our patient is at the top and is the center of everything we do. I think that also helps us neutralize conversations as we try to think about how do we advance care that's all about the patient, and how do we come together with a shared goal of that patient, not what's the surgeon's, what's the surgeon's goal in that. It's we all have one goal. It's all about the patient. And our vision to be the quality leader and transform healthcare, I think this is just one example of the programs that we've really embraced and trying to see how we can partner with others to improve the healthcare of our community in our region and transform that. I think an important piece of this conversation too is that we also are very committed to the Virginia Mason production system. It's the foundation of our pyramid, and it's really how we do our work. So we have this true vision around our patient-centered care. And then we have a very organized process improvement a tool that we use with regard, it's Kaizen, and it helps us really concentrate on how we improve the care for our patients. It's also unique in that we have patients involved in our workshops and helping us understand how to deliver a better patient experience. Next slide. So total joint replacement at Virginia Mason, we actually had, back in 2010, a very robust visioning session with all of our care team members. It really was intended to develop a team-based approach to care, from how a patient enters our system to how we get them back home and return to function. That's a really important piece of how we think of this. It's not just getting a patient home, it's how do we get them how do we improve their return to function and their quality of life. It's evidence-based. We spend a lot of time on understanding our care delivery and how we can improve it, with the goal of improving return to function and improving quality of life. Patient-focused, clearly we really want to engage our patients in helping us improve the experience piece of that and how we even communicate with them. Reducing complexity, we spent a lot of time with our patients trying to smooth our processes out so they're very patient-centered. Continuous improvement, we are continuously looking at not only how we deliver care, but the outcomes and how we can continue to improve the quality of care for our patients. And we launched our first bundle in 2014, and that was through partnership with Health Design Plus. We follow the BRIE Collaborative for all of our patients. So a lot of how we look at our patients is we ensure that every single patient has the same clinical experience. And that is really to understand and recognize the patient. That's the appropriate piece of the BRIE bundle. Are they ready for surgery and safe for surgery? Restoration and surgery, correcting the problem, and then recovery and outcomes. How do we ensure that they have returned to function and their quality of life is improved? Next slide. Delivering on the bundle. So the BRIE bundle is 4 components: appropriateness, and this is really understanding the disability and what non-surgical therapy has been tried to date, and if not, stepping back and ensuring that conservative therapy has been tried so we can understand what's the best intervention for that patient. Safety, fitness for surgery, and shared decision making. There's 2 components to this. Is one, are they really safe and will they have the best possible outcome? And if not, how do we optimize them to have the best possible outcome? And shared decision making, does the patient understand all of the different possible interventions and what's best for them, not just from a clinical perspective, but what fits with their goals and what they're trying to achieve as they improve their quality of life, and how we partner on that together. Evidence-based surgery, this is really focusing on how do we understand and document our adherence to the quality standards and appropriateness and safety, and ensuring that we have a very visible process to follow and make sure that we are, for every single patient, following the evidence-based guidelines that we have agreed to. And then return to function. For all of our patients, we do collect patient-reported outcomes prior to their surgery, and then at 6 and 12 months. And the important piece of this is not just around returning to function, it's their pain level. And there's a lot of questions that we ask our patients to try to understand if we've really improved their quality of life. Next slide. So cycle 1, I've kind of covered these, so I'm going to speed through these a little bit. Function measured on a standard scale, so all of our patients get the exact same baseline measures, and to qualify for loss of physical function. We have an x-ray for every patient, and depending on their clinical symptoms of also including the results of those x-rays, determine the severity of arthritis. And then our non-surgical care, if they don't have severe arthritis demonstrated on x-ray, then we have a standard of physical therapy, weight loss, injection if indicated, and very committed to non-opioid pain medicines. Next slide. Cycle 2, reducing the risk of avoidable complications. Our primary goal is to ensure that our patients have the best outcomes and return to function. So this is a very important piece of our process. All of our patients meet 13 clinical criteria, but these 4 are, I would say, the most, we spend a lot of time on these because they really are important to this process, and I wanted to highlight them. The patient's BMI, which was alluded to earlier, nicotine-free for at least 4 weeks. This really has a lot to do with how they heal an infection and reducing the risk of infection. Controlled blood glucose level, same reason, it really improves their outcome. If their diabetes or A1 is under control, it also improves, reduces the risk of infection. And then mental and physical risk documented and assessed and addressed as necessary. Patients must have a care companion. This is really important to their hospital stay and their outcomes, shared decision-making, health coaching, and then high-risk patients needing surgery. So any patient that is not meeting any of these criteria, they go to peer review where we have multiple surgeons look at that to ensure that that patient, the risk is higher, is necessary and to proceed with surgery, and then those patients do fall out of the COE process. Our pathways are specifically and intentionally set up to reduce risk and improve outcomes, and I'll talk a little bit about cycles 3 and 4 next slide. So best practice for surgery. This is very much focused on our surgeon volume, not starting elective surgeries after 5, really engaging with our anesthesiologist with multimodal anesthesia that reduce pains so we can decrease our use of opioids, and then standardization with our implants, and then reporting to a national registry so that we can ensure that we are aware of any implants associated across the country where they might be used elsewhere. Next slide. Return to function. So at the top of this slide is a visual pathway for all of our patients, and this is actually, we use this tool to educate prior to surgery and then in the hospital stay, so that our patients are clear about what are the benchmarks that they need to achieve to get home. And the last one is actually, can they safely get in a car? And we actually have a car model in our inpatient hospital area where we can test and ensure that patients can get in the car and get safely home. The bottom slide is just some information around our patient-reported outcomes, but prior to surgery and post-surgery, and you can see that we've been able to achieve improving our patients' function and quality of life. Next slide. Briefly, just to touch on our outcomes, appropriateness, documentation of conservative care is greater than 90%. Standards of evidence-based care, receiving measures to reduce infection is at 100%. Patients receiving DVT precautions, which would is around safety for their OR and for their outcomes, is 99%. Ensuring rapid return to function. There's a lot of research and evidence that the quicker you can get patients up and walking, they will have a better outcome. And so our patients have PT within 24 hours is 99.3%. As was also John covered, our patient experience, our patients enjoy the experience. They feel that they've been supported and are likely to recommend is 9.78 out of 10. And this is actually for all of our patients for orthopedics at Virginia Mason, not just our HCA patients. And that actually applies to all of these outcomes. And safety and affordability. Our readmission rate is very low at 30 days. That's all cause readmissions, and then warranty readmissions, which is a subset, is 0.2%. Next slide. A quick program summary. Really our care is really around appropriate care, evidence-based, shared decision-making. Do you need it? Do you want it? Is a really good way for us to explain that to our patients. It's comprehensive. It's more than just surgery. Surgery is only a piece of that pie. And removing variability. We're very standardized in how we approach our patients and our clinical care so that we have the best possibility for good outcomes for our patients and for the best possible patient experience. It's predictable pricing within the bundle, and so that locks in the purchase price. Next slide. Just quickly, a few lessons from Virginia Mason. Leadership, engagement, and physician champions are essential. It really does take the entire system and a village to ensure that all of these measures are taken for safe patient care. There must be accountability for all roles, including your surgeons, and relationships. I think we would all say this, that the relationships we've built to deliver this program have been exceptional, and I think contribute to the success of the program. Back to you, Marty.
Okay, thank you very much, Krista. We'll be transitioning into the last part of the webinar now, looking at some of the details regarding the program after a year in operation. First, I just want to say a couple of things about the data to which I'm referring. I like to use the most up-to-date data I have. I get some reports weekly. I get some reports monthly. For our cost data, I'm referring to surgeries billed and paid. That's less than the 95 we did in 2017. Demographics, I like to use all the referrals we get because that is the sum total of our participants. I mention this just to stress that these data are going to be changing every month. But that said, the costs, the percentages, the demographics are falling into patterns, and that's what I'm reporting on today. And incidentally, the difference between 95 surgeries and 122 referrals is not necessarily that 122 minus 95 are those people who weren't appropriate for surgery. Some of them have received surgery since, others are still in the pipeline, and so forth. Moving on to participant distribution. This displays most of our referrals. You can see the darkest areas are along Puget Sound, where we have the densest population. But you can also see that we have members are coming to the COE from around the state. I think this is an interesting chart because if you had a similar chart of the distribution of Washington state population, it would look almost exactly the same. Between east and west, I think it's 78 to 22%. King County's around 30%. And Puget Sound, Whatcom to Thurston is about 61%. So very even distribution where our participants are coming from. This is about PEB member interest. These are data that come from Primeira. The top line, the number of visits to the website. The next, the calls to the customer service desk. And then blue is the welcome packet sent to people interested in the program. The green line on top is very interesting. We haven't been able to figure out what the bump is about March of last year, whether some publication went out. We just don't quite have that pegged. But definitely the steep rise in November, you can see what open enrollment did to the interest among PEB members. Lots of website hits and even a rise in calls. Moving on to age and gender. The 60-40 split female to male is consistent with the national trends. Women have a higher prevalence of arthritis and worse symptoms and usually greater disability. They also have greater incidence of cartilage loss and hip degeneration. So it's interesting to see a national trend manifested in our small sample. Regarding age, the nearly 25% of 65 and older, we're assuming these are people 65 and older who are still active employees, and therefore Medicare is not their primary coverage. And as could be expected, most of these surgeries are being done with people 45 to 64 currently active employees. Plan and surgical site. Of all the people eligible in the classic and CDHP plans, about 92% of them are classic, so these proportions are roughly proportional. CDHP may have a little less than its proportion because of that having to pay the deductible down before participating without cost. Knee and hip, nationally, I think the split is more like 70-30. We've got a 60-40, but we're falling in line. Now, looking at costs, if you look at the pie chart upper left, let's see. One moment. A question might be when even travel expenses and even airfare are included in a benefit, that might at first seem like a very extravagant thing to do and could inflate costs. But if you look at that pie chart, you can see that 97% of all costs of the program are medical, with only 3% travel and administration. The lower pie chart is a breakout of the travel benefit. You can see the lodging is the lion's share, and not many people are flying. It's not a very big expense. And our parking expenses, it's downtown Seattle. We have taken note of that, and that share is dropping as we adjust. So this I want to describe for you. This is our primary cost slide. Our 2017 data are not complete, so we're just portraying this through visual proportions. So I'll walk you through it. The first bar to the left is the average facility and professional charges paid, average paid per total joint replacement for the eligible population in UMP. And that's the average for 2014 through 2016, nearly 2,000 surgeries. The middle bar is that same average per total joint replacement in 2017 for those who did not go to the Center of Excellence. And the final bar on the right is what the state is paying on average for a joint replacement at the Center of Excellence, and that includes travel benefits and administration. So there are two data takeaways from this chart. First, the average joint replacement cost for non-COE surgeries rose in 2017 compared to the previous 3 years. Second, joint replacements performed in 2017, last year, at the Center of Excellence cost noticeably less than both of those averages. And noting the comment beneath the chart, when there is no out-of-pocket cost, these 95 members saved about $900 each. I think this is a notable outcome for the first year. To recap, eligible UMP members can have their total joint replacement performed at one of the top medical centers in the country for joint replacements. They can do it without a copay, and they can do it while the state saves money. That's value. And the good news continues. One of Primeira's key roles, as John was saying, is to survey the participants after their surgery. Among other things, the survey asks, would you use the program again? Would you recommend it to friends and family? And what's your overall satisfaction with the total experience? As you can see, the average scores after 54 return surveys was between 9.5 and 9.8, which indicates a high level of broad appreciation for this benefit. Here are just a few of some of the early comments we received from surveys. Along with these participant accolades for the benefits, suggestions for improving our operations have helped us to develop the program further and to improve the patient experience. So some takeaways. This isn't an exhaustive list, but here are just a few after more than a year with the joint replacement bundle. Clinical best practices are the center of a center of excellence. Best practices are where good outcomes come from. Also, seriously attending to the patient's journey is a key to success. What they experience and how they're treated, start to finish. And something I haven't mentioned, this benefit functions with a prospective payment. That's an upfront, contractually agreed upon price for the bundle. Prospective payments bring clarity and control to costs and avoid the need for an involved process of financial reconciliation after the fact, after the end of a year or a quarter. Most of all, and I separated it with a separate bullet, the teamwork. Krista mentioned this. Our three organizations share a commitment to the best health outcomes possible for our members. Each of us has a role. We all know we can successfully work through the issues as they arise, so long as we keep that common shared commitment. It's just not about us. We keep our focus on the members. So with that, we'll do our best to respond to any questions or comments you have. We have a few here, and please feel free to use the webinar page to submit any more. I'll pose one that I can answer first. What percentage of your members are using the Center of Excellence? Well, when there are about over 200,000 people who are eligible for the benefit, not that many. But as I noted earlier, there are between, say, 600, 650 total joint replacements per year in the eligible population. Of that amount last year, maybe 12 to 14% selected the Center of Excellence. I have a second question, and Krista, I'm going to throw this your direction. In determining the severity of arthritis, who is determining the Keldron-Lawrence scale, the operating physician or the radiologist?
We can get it in two different ways. It could come directly from the radiologist, but we also get a copy of the x-ray that our surgeon looks like, or the surgeon could look at it. So it could be both. It could be either.
Okay.
But we get the x-ray along with the report.
Thank you. Another one to you, Krista. Are patients required or encouraged to go through the patient decision aid or shared decision making? You talked about that a little. Just what does that look like?
With regards to the COE patients, we do require them to go through it. What happens is, and if they need help, we're happy to help them. So they go, it's electronically based, so they go through the surveys. And then part of that also is some education around osteoarthritis and different interventions available. And then there's some health coaching that also can come out of that. And because there's some and we get to that information based on the surveys that the patients complete.
Okay. Okay, thank you. I'll ask one that I think I can answer. How many members, or maybe I'll pose this to you as well, Krista, how many members are told, well, I think maybe I can answer this. How many members are told they are not eligible or appropriate for surgery and then go get a hip or knee replaced somewhere else? My understanding is, Virginia Mason's experience is that is less common than you'd think. At the Healthcare Authority, we are just now looking at the experience in the data for 2017. And again, those claims can roll in for months. So the data is going to be incomplete for quite some time. But Krista, I will ask you, because Virginia Mason has done so many joint replacements, what has been your experience regarding those who may go elsewhere or not?
It can happen. We don't see it routinely. We've started to see it less and less.
Okay. All right, I have another question. How did you get employees to agree to this? That's an easy one. When we offer them a serious, expensive surgery with nothing out of pocket, it didn't take much. Any pushback from labor? No. I think perhaps there could have been some if it was a requirement, but those eligible can still go anywhere they want for their surgery. They aren't forced to go to the Center of Excellence. Let's see. And this, Krista, I'll throw this to you. How does your COE address follow-up care in the members' community? And John, feel free to chime in if this is something you can address as well.
We work in partnership with their primary care provider, as well as we have specific intervals that we communicate directly with the patient to see how they're doing. So it's two-pronged approach that helps us stay in contact with that patient and ensure that they're progressing as they should, and what their resources are if they need additional care. You know, on that previous question, I just thought of another kind of caveat to that. I'm not sure who answered it or who asked it, but around patients getting care elsewhere, I think the reason why we also don't see that very much is that we're really clear around the plan of care, and that surgery is not a good thing. That's our last resort. What we want to do is really provide them with a clear understanding of when they're ready for surgery. We can do that, but we want to make sure that the patients really understand why surgery isn't an option or isn't the best option clinically at that time. So that's probably another reason why we don't see patients going getting care elsewhere. So we're really careful about that comprehensive answer.
Okay. All right, thank you. Boy, we're getting a lot of questions. Where to go next? This is an interesting one, having to do with the relationship between our three parties. What is the financial relationship between Healthcare Authority, Virginia Mason, and Primeira? For example, is Primeira a subcontractor of Virginia Mason or Healthcare Authority? And if so, are they charging a flat rate, case, or et cetera? What I have found so great about this three-way partnership, the Healthcare Authority does have contracts with Virginia Mason as the Center of Excellence for this bundle. It also has a contract with Primeira as the third-party administrator of our Center of Excellence program, which means Primeira will likely administrate other bundles as well. Now, why I find this such an interesting question is the very close relationship that Primeira and Virginia Mason have built, just developing the operations for how they coordinate care and the patient's journey when they do not have that contractual relationship with regard to this bundle. Krista, John, would you have anything to add there?
This is John. So I think we approach the relationship as really an opportunity to build bridges based on where we want to go in the mission of the program. Marty, I think that the Healthcare Authority has really carefully laid out the desire and vision of value and value-based care according to the BRE criteria. Virginia Mason really showed a lot of innovation and leadership in committing to that path. And then Primeira, really as a service concierge, is really focused on that patient experience and care companion experience, and then making them really an ideal patient for Virginia Mason by qualifying the referral. So it's really it's a collaborative effort.
Sorry, I would just add to that. I think, I think all of us are continuously committed to improving the patient experience and the outcome for the patients. And I think that's the relationship is important because we meet so often to continuously understand how we can become better.
Yeah. Okay, thank you. We might have time for one more. And incidentally, if there are questions that I don't quite get to during this webinar, we do have access. We can, I'll do my best to respond to you when we are offline. We know the email you're coming from. But this is for Virginia Mason and Primeira. How pleased are Virginia Mason and Primeira with the uptake on the program? Looks like about 1 in 6 surgeries are done at the Center of Excellence in 2017. Also, since geographic, demographic mirror the state population, doesn't that indicate that the Center of Excellence has not increased the draw from non-metro areas? Either one of you.
John, do you want to go first, or you want me to?
Marty, yeah, Krista, let me take the first piece of this. If I'm not mistaken, Marty, geographically, it's an even distribution. So in other words, the 14-15% of the folks that choose to go into this program are evenly dispersed throughout the state. So that, I think, is a comment on just the desirability and attractiveness of Virginia Mason as a COE, and that folks aren't letting their geographic location be a barrier to putting themselves into this program.
Thanks. All right. Go ahead, Krista.
Oh, sorry. I was just going to say we're very pleased because it gives us the opportunity to continuously improve that patient care in partnership with the HCA and Primeira. And it gives us another opportunity to just look at how we can improve quality and reduce costs with strategic partnerships.
Okay, great. Incidentally, the Healthcare Authority is very soon to release another RFP for another bundle. And let's see. Oh, another question. Has the Healthcare Authority looked into post-op complication rates, readmission? The answer to that is we are in the process right now. There is a claim run-out period, but we are trying to get that those data together right now. And of course, the clinical side of the entire operation is very interested to see what the post-op results look like. I think we've used our time. I'll try and get to any questions we didn't address offline, and I hope this has been a good hour for everyone. Please feel free to contact any of us using the information on the slide that was up before this. And thank you so much. Have a great Valentine's Day.